So from the Leeds Teaching Hospitals NHS Trust, would you please welcome Mr. Martin McKibbin.
Thank you, John, for your kind words. I'm not sure about the eminent title. I think to my children it's just old. So it's a great pleasure to be here today to speak to so many people, and particularly at the end of National Eye Health Week. I'm sure macular disease is featured eminently in that. And I was also very interested listening to Desert Island Discs last night to see that macular disease featured in it. Those of you who are Radio 4 fans may have heard it. So it was featured Judi Dench. And if you're not familiar with the scenario, at the end you get to choose your songs that you take away with you, and you get to choose a luxury and a book. And Judi Dench, who's got macular disease, said she would like to combine the two together. So rather than a book, which she can't access because of a macular disease, she wanted an audio book and an audio player, and it was of her daughter speaking. So I don't know if that was by coincidence or by design, but it was good that that was a feature of National Eye Health Week. So Kathy asked me to speak about two things: the causes of macular degeneration and current treatments. So I'm not allowed to speak about future treatments, which is good, because that's quite a difficult thing to summarise. And I'm going to focus on age-related macular degeneration, myopic macular degeneration, and macular dystrophy, because I was trying to guess that that would probably cover most of the people in the audience who've got macular disease. So with most diseases, we get it due to a combination of genetic factors and environmental factors. So we all have about 25,000 different genes, and we get a copy of each gene from both of our parents. So as ever, you need to choose your parents with great care. But we can't blame everything on our parents, because there are some things that are not genetic and they're called environmental. And they might be increasing age, they might be diet, or they might be your working environment or your income. So for everything, there's a sort of combination of both genetics and environment. So to illustrate this, I wanted to go off on a bit of a tangent to talk to you about tomatoes. So outside of work, I'm an enthusiastic but not very good gardener, and one of my interests is in vegetable growing. So I don't know if anybody knows what is the world record for the single biggest tomato. You can shout it out. Well, you might be wrong, but anyway, any ideas? I know. £50. £50? That might be the value. Anyway, it was £7, 12 ounces. I mean, that's a big tomato. So, Kathy, you need to enter the competition. So, last weekend, it was the Harrogate Autumn Flower Show, and in the Harrogate Flower Show, they're quite keen in the autumn time of year on giant vegetables. So, if you grow the biggest, or if you get a new record for the Harrogate Flower Show in any vegetable category, that's worth £1,000. And if you get a world record, that's worth £5,000. And competitive people like myself, being what they are, this is obviously subject to some skullduggery. So one of the categories of giant tomato is the gigantomo category. And obviously, everybody needs to be growing the same variety, because they're all genetically, they're the same. So I was interested a few weeks ago to discover that they're going to do genetic testing now, such as the amount of skullduggery in the giant tomato category. So the organisers of the Harrogate Flower Show want to make sure that every tomato in the gigantomo category is indeed one of those tomatoes. What they're really looking for is the skill of the grower. So they don't want somebody who's got an even better variety. They want to put it down to the skill of the grower. So what they're trying to do is take out the genetics and give an award for the best environment in which the tomatoes were grown. So that's the gist of it. And then another thing I wanted to illustrate was the idea of living longer. So we all know that people are living longer nowadays, and compared to somebody born in the 1980s, a child born now is expected to live for about another 10 years. And if you project this forward, a child born in 2050, the average age is going to be 100. And so I was thinking, I'm 49, I thought, gosh, living to 100, you've got a lot to look forward to. So you might wonder, why is it that we're all living longer? So one of the ways in which you could look at this would be to study twins. So by and large, most twins live in the same house, they have the same diet, they go to the same school, they probably share the same clothes, although I'm not sure the clothes has got much to do with it. So if you look at identical twins, by and large, they'll also share the same genes, compared to non-identical twins who have the same environment, but they won't share the same genes. So if you look at the difference in life expectancy between the identical twins, where everything is the same, versus the non-identical twins, you can work out how much of your lifespan is due to genes and how much is due to environment. So only about 30% of our lifespan is related to our genes, which we can attribute to our parents, and the remaining 70% is due to environmental factors which we can control. So that might be smoking, alcohol, diet, and exercise. So again, it's partly genetic and partly environment, and that's the same thing for most macular diseases, as indeed it is with tomatoes. So for age-related macular degeneration, the biggest risk factor is increasing age. So if you look at the frequency of age-related macular degeneration in populations from Australia, Holland, and North America, only about 1 in 500 people around about the age of 55 will have age-related macular degeneration. And if you look at people who are about 65, that rises to about 1 in 100. And if you look at people about 80, that's going to be up to about 1 in 20. And once you get over 85, it's about 1 in 8 of the population will have features of age-related macular degeneration. So some of it is increasing age, but also smoking is quite a big factor. So a smoker's got 3 times the risk of compared to somebody who's never smoked. And if you're an ex-smoker, your risk drops down, so you've got about half the risk. So we can't do much about our age, but we can do stuff about smoking, and I'll come on to diet in a minute. So some of the risk for age-related macular degeneration is environmental, and some of it is also genetic. So we know that macular degeneration runs it in families, and if you've got a first-degree relative, then your risk of getting it is about 4 times the risk of somebody who doesn't have a history of it in the family. And over the years, it's been worked out there are about 20 different genes which are involved in your risk of getting age-related macular degeneration. The function of some of these is known, the function of others isn't yet known, and some of the genes will increase your risk, where others will actually reduce your risk. So I said before that we all have 2 copies of every gene, 1 copy from both of our parents. And about 10 years ago, the gene that's most important, called complement factor H, was identified. So genes are sort of instructions, are a bit like a recipe, and if there's a spelling mistake in a gene, it can alter the way that the gene works. So there's a particular position in the gene called 402, and if you've got a bad spelling mistake in that gene, it adds to your risk, whereas if you've got a good spelling mistake, it probably reduces your risk. So people who've got 1 spelling mistake in that gene have about double the risk compared to somebody who doesn't, and if you've got a bad spelling mistake in both of those copies of the gene, then you've got about 7 times the risk of somebody who doesn't have either copy. So about a third of us probably in this room have a bad spelling mistake in the complement factor H gene. We're not all going to go on and get age-related macular degeneration, but it definitely increases our risk. So this complement factor H, or CFH gene, is a part of the complement pathway. This is part of our body's natural defense to infection and to insult, and the complement system is always ready to be activated, and it seems to be triggered by a variety of things, and it's not entirely clear yet what triggers it within the eye. But at least 50% of the risk of getting age-related macular degeneration is down to genetics, and the biggest gene, the most important gene, is complement factor H. So the second gene is a gene called ARMS2, which is age-related maculopathy susceptibility gene number 2. And about 30% of us have this. And as with complement factor H, if you've got 1 faulty copy of this gene, you've got double the risk. But if you've got 2 copies, you'll have about 7 times the risk. And so both of these genes add to our risk of getting age-related macular degeneration. They might also alter the type of macular degeneration you get. So people with spelling mistakes or faults in the ARMS2 gene typically they're more likely to get wet macular degeneration rather than dry. And there's some evidence to suggest that having your genetic makeup might also influence how you respond to conventional treatments. So we've talked about genes, and I've talked about environment. So just try and remember that for everything, it's partly genetic and it's partly environmental. So I was now going to move on to myopic macular degeneration, or macular degeneration related to short-sightedness. So most of you will know that if you're short-sighted, it means you can see things close up, but you can't necessarily see things far away unless you wear glasses. And probably about 20% of the population is short-sighted. And if you looked at a sample of people in the UK now, it's actually quite rare before going to school. It starts to become more common in school-age people, and then it's most common in people of sort of university age. And then in later adult life, my age, it's quite rare, and then it becomes more common as people get older, but that's probably related to cataract. So, and going back to short-sightedness, it's partly genetic. So if you've got one parent who's short-sighted, you've got about 4 times the risk, and if both your parents are short-sighted, you've got about 6 times the risk of somebody who doesn't have a short-sighted parent. It seems to be more common in people of Asian background, Caucasian background, and interestingly, it's more common in people of high intelligence, which is probably why I'm not short-sighted.
I am.
And it seems to be more common in professional people and well-educated people. So looking around the room at the short-sighted people today, I'm sure, as Kathy illustrates, that is indeed the case. And as a parent, I'm often, reminding my children that life is not just on their phone and on the iPad. So interestingly, it's becoming a lot more it's becoming a lot more common. And one of the risk factors is the amount of time you spend doing near work, so reading, looking at computers, perhaps you're playing on your phones. So that might explain why it's becoming more common. Those are things that add to your risk. Whereas children who play outside a lot, as perhaps we all used to do in older generations, they seem to be protected. So as with age-related macular degeneration, myopic macular degeneration is partly genetic, but it's also partly environmental. So I do remind children that a nagging parent is often right. So the third group of conditions I was going to talk about are the macular dystrophies. So as John mentioned, there are many different types of macular dystrophy, and the commonest ones that I see are Stargardt macular dystrophy, Best's macular dystrophy, and then pattern dystrophies, and they affect people of different ages. And for most people who've got this, it's nearly all genetic. So they have either 1 or 2 faults or spelling mistakes in a particular gene, and it'll be one of our 25,000 different genes. And in general, if you've got the particular spelling mistake or combination of spelling mistakes in that particular gene, you're going to go on and get the disease. So for macular dystrophies, it's the ratio of genetic and environment is very much genetic, and environment plays probably relatively little in it. And people who've got a macular dystrophy typically lose vision because the retina gets a bit thin and worn out or threadbare. That's equivalent to dry macular degeneration. And I often use the analogy to the patients that I see of saying it's a bit like the heel of one of your old socks. It just gets thin and worn out. And only a small number of people with macular dystrophies go on and develop wet macular degeneration, which is obviously the biggest cause of visual impairment to people who've got age-related disease. So talking about wet and dry brings me on to treatments, which is meant to be the second half of my presentation. So the first thing about treatment is obviously prevention. I know the Macular Society has a campaign to inform people about the risk of smoking, and we said smoking is the biggest risk factor, and the best thing you can do to reduce your risk is probably to stop smoking. And there might also be something to do with diet. So several years ago, the Age-Related Eye Disease Study, or the ARED study, looked at the effect of vitamins A, C, E, zinc, and copper on progression of age-related macular degeneration. And they had people in 4 different categories of early and late macular degeneration, and they gave them either a placebo or a tablet containing each of these key vitamins to look at how the disease progressed, both in terms of the anatomy and also the function. And the headline data from the study suggested that it made between a 20% and 30% reduction in the risk, which sounds quite good. But when you look at that's the relative risk reduction. When you looked at the actual risk reduction, it probably reduced the risk of progressing to the bad endpoint by from about 25% to about 20%. So when you look at the absolute risk reduction, the benefit was actually quite modest, and that was taking these vitamin supplements for a period of 5 years. Since then, the AREDS-2 study has looked at the effect of adding lutein, which is something I'm sure this audience knows a lot about, and also essential fish oils. And I think the summary of the data was that probably that is advantageous. So I think if I had age-related macular degeneration in one eye, I would probably take a multivitamin supplement. I know the Society has sponsored research which did a telephone survey of members to try to work out how much lutein do they get in the diet, and only a small percentage got the recommended 10 milligrams that's needed to top up your macular pigment. So probably most of us are not going to suddenly change our diet, and as a result, I think it may be worthwhile taking a vitamin supplement, but the benefit is modest. So in terms of active treatment, I think in Leeds we're signed up to the idea of giving accurate information. We try to make sure everybody gets correct glasses, and we stress the benefits of low visual aids or magnifiers. And we do inform people about some of the steady eye strategy and the revision programs that the society promotes. And we try to be, positive and to give people accurate information. However, at the moment, the number of treatments that we offer is by and large limited to people who've got wet macular degeneration. And following NICE guidance, so NICE is the national body that regulates access to expensive drugs, in Leeds we can use a drug called Lucentis or ranibizumab, or a drug called Eylea or aflibercept to treat people who've got wet macular degeneration. So NICE guidance says we can use it if your vision is below a certain amount, so actually below the legal limit for driving, but it can't be too bad, and there has to be evidence of disease progression, and we have to have a reasonable expectation this is going to do some good. And both of these drugs target a molecule called VEGF, or vascular endothelial growth factor, and that seems to be produced in excess in people who've got wet macular degeneration. So the drugs sort of mop up or bind VEGF, and that's how they seem to work. Recently, there's been quite a lot of debate about a drug called Avastin or bevacizumab. Many of the audience, I'm sure, were involved in a UK study called IVAN, which was comparing Lucentis and Avastin. And in essence, it said the two drugs are by and large the same. So because Avastin is a quarter of the cost of the other two drugs for the NHS, a lot of the CCGs who commission healthcare products ask the Department of Health, should the NHS not be using Avastin compared to Lucentis? So an injection of Avastin in Leeds costs about £100, a vial of Lucentis costs about £450. So if you're having this up to every month, you can see how the cost adds up. But the Department of Health said no, Avastin has never been formally tested and declared to be safe in people with eye disease, therefore we're not going to use it. And I think that was generally a good thing. I think it tended to show that patients with eye disease are not going to accept an unlicensed product. And as Kathy alluded to, I think any cost savings wouldn't have necessarily been ploughed back into research into other eye diseases. It would have gone off to sort out and overspend somewhere else. So I think the key to getting a good outcome if you've got wet macular degeneration is first of all to start off early. So we know from a lot of studies that if you've got wet macular degeneration and it's caught early and you start early, you might not get a big gain in vision, but you tend to keep that sort of level of vision. So if you can start off and you're still eligible to drive, then probably you're going to remain able to drive. And in Leeds, we're very signed up to the idea of fast-tracking people who are suspected of having wet macular degeneration through the clinics. So for most eye conditions, the routine wait allowed in the NHS is 18 weeks, whereas for people who are suspected of having wet macular degeneration, we try and see them within 2 weeks. So anyway, start off early. I think the second thing is to make sure you get as much drug as you need. And nowadays, I would always err on the side of caution. So if I'm unsure, treat or not treat, I would usually recommend just treating it. And we do so many injections now that in Leeds, I worry more about the people I don't treat than I worry about the people that I have treated. And the third thing is probably to try to make sure your hospital department has got adequate capacity. So I've been giving intravitreal injections since 2006. I never in my wildest dreams imagined I'd still be doing it 9 years later. And when I started in Leeds, I was the only person doing it. So we had one injection list a month of 8 people. That was it. Now we've got 10 clinics a week. We're almost at full capacity. We do 5,000 injections a year. And it's only going one way. It's not going to come down. It's only going to go up. So we struggled in the past to see people every month, which is what we knew we had to do previously. But now with different regimes, we can see people slightly less often, and we seem to be able to get similar outcomes. So you probably need to know what sort of capacity does your local eye department have, and also what's the plan for you. So by and large, there are 3 sort of regimes which we might treat people with. Some people we will see either monthly or at a longer interval and treat them every now and again. So we'll only treat them when we think the disease is active. And for a lot of people who have been on Lucentis for some time and are still coming along to the clinic, that seems to work reasonably well. Another approach is to see people and treat them every time they come, but at increasing intervals every time, and that's called treat and extend. So the idea of that would be that if you saw somebody who you knew was stable at 4 weekly treatment, you might try and take them to 6 weeks or 8 weeks or 10 weeks. Eventually you'll go too far and you need to bring it back down. And then there are other people, particularly with this newer drug called Eylea, who we know we can treat monthly to begin with and then swap them over onto 2 monthly treatment and then possibly onto 3 monthly treatment. And I think it might be worthwhile trying to work out with your local eye clinic what regime are you on, because I know a lot of people that I see in Leeds say, have I been, you haven't seen me for 8 weeks, is that not too long? So they don't potentially realise that actually, no, that's what was planned. So I think you've often got to know what sort of regime works best for you, and that will perhaps put your mind at ease so you know that you're being seen at the right sort of frequency. So I know a lot of people will have dry macular degeneration, and although it's not necessarily within my remit, because I'm not talking about future treatments, there are a whole host of new and emerging treatments for dry macular degeneration. They target a variety of pathways, and I couldn't summarise them even if I gave the whole half hour to it. The one that's currently being studied in the NHS is a drug called lampalizumab. You can see how difficult it is to pronounce some of these drugs, and that targets a molecule called factor D. And it's said to reduce the risk of progression of dry macular degeneration by 20% overall, but by almost 50% in people who've got a particular genetic makeup. So there's a phase 3 clinical trial looking at that drug ongoing. It involves about 900 patients around the world, and it's involved in many centres in the UK, but it does require 4 to 6 weekly injection of this drug into your eye. So anyway, that's something hopefully that's going to come. So I wanted to finish by talking about outcomes. So I think it's assumed that the NHS is using expensive drugs and getting good outcomes, but actually that's not always the case. In Leeds, we audit our outcomes of patients we've treated for macular degeneration every year. The first time we did it, I was slightly embarrassed to see that we weren't getting the same sort of outcomes from patients being treated in clinical trials, but I now realise that actually probably nobody does that. Within the NHS website, if you're about to have your knee done, you can go and look up the complication rate for your individual surgeon, and you might say, actually, I don't want him to do it. I'd like this younger, more efficient model to do it. And you can do the same for hip surgery, and you can do the same for cardiac surgery. So there is, at some point, probably next year, you'll be able to do that for cataract surgery. You'll be able to look up the hospital, your local hospital, and see what's their complication rate compared to your next door hospital. And you'll also be able to look in on your own individual cataract surgeon. And I'm quite pleased I don't do any cataract surgery anymore, so that won't be my dirty washing head in public. And Kathy and I have been involved with the College of Ophthalmologists in a project funded by the Department of Health to provide the same sort of data for units to provide treatment for wet macular degeneration. And we're still unsure about what sort of data will we collect and how detailed it will be, but it will definitely involve vision. So in Leeds, we collect our data and we compare it to other places, and we know that probably the two biggest things that determine what's our average outcome are the age of the population that we're treating and also what was their starting vision. So I said before that if your population starts off with very good vision, they tend to keep that vision, but they may not get a big gain. Whereas if they've got really poor vision at the beginning, they're always going to have poor vision, but they might get a modest gain. So we know that those things make a difference. And I think the idea is that you will be able to look up how your eye department is doing and see if the average change in vision is good for that department compared to others. And it's all down to choice. So if you live in London, I'm sure geographically, it's quite a short distance to go from one eye department to the other. But if you live elsewhere in the country, probably you don't have that choice. But I think the hope is that while you may not be able to choose to go to a different eye department because it's usually much further away, hopefully the departments which have got good outcomes will keep their good outcomes, and the ones which have got poor outcomes will be shown up as having poor outcomes, and there'll be a drive on those to improve and to catch up with the others. So hopefully over time, this will be a mechanism for ensuring that all NHS units deliver expensive drugs for wet macular degeneration and get the good outcomes that they're meant to do. So that's all I've got to say. Thank you. Kathy wanted me to ask some questions.
Thank you very much.
Thank you, and John too.